All right, this is our defense presentation. Our project is over the effects of midazolam on postoperative nausea and vomiting. I'm Jessie Franklin.
Sarah Haas.
Alexandria Howell.
Okay, so first off, we would like to acknowledge our committee and our primary investigator, Dr. Megan Cook, and then our research committee members, or Dr. Michael Bradley and Matthew Merrill. We just want to say thank you to all of them.
So PONV is something that we know affects us every day that we go to the hospital. There's not many things that I can think of that we encounter every single day. So I thought it was a good thing to study. This idea was brought to me through a friend that was a CRNA, and I thought it was interesting. So we really enjoyed digging into PONV and midazolam as an antiemetic. PONV is known to be reported by approximately 30% of all surgical patients. And as we know, many patients describe it as even more detrimental than post-surgical pain. With the knowledge that PONV is best treated with prevention administration of at least 2 antiemetics from one of the 6 different drug classes, the authors of this literature review aim to determine the effectiveness of midazolam as one of those antiemetics.
So our problem statement includes that anesthetic agents and opioids are implicated as the root cause for nausea and vomiting postoperatively. Hopefully by decreasing our postoperative nausea and vomiting, our patient outcomes will be improved. Barring any contraindications, adding midazolam to standard PONV protocols would provide an improved coverage for PONV prevention.
So we came up with the research question for our project of, does preoperative administration of intravenous midazolam decrease the incidence of postoperative nausea and vomiting after general anesthesia?
Our theoretical conceptual framework that we chose was Faye Glenn Abdallah's 21 nursing problems theory. She theorized that nursing care should be individualized and specific to each patient. This shifted the focus from disease-centered to patient-centered. Her framework has been published over 150 times. She used it in work with public health, AIDS, and many other things, and it's known all across the world from Japan to China to the United States. We chose this framework because PONV prevention greatly affects patient outcomes, and patient-centered care can greatly change that outcome. The choice of the antiemetic should be patient-centered and not disease-centered.
Our design, we chose to do a literature review of studies and trials evaluating midazolam as a preoperative antiemetic. A quantitative correlational design determine if a relationship exists between independent and dependent variables. Our independent variables are preoperative midazolam administrations with or without standard antiemetic medication protocols. And our dependent variables are postoperative nausea and or vomiting or the need for rescue antiemetics.
Next is the method for our project. Our data collection plan started with search terms of midazolam, antiemetic, postoperative nausea, postoperative vomiting, and perioperative. And we use those terms in the EBSCOhost database at the Newman University Library. Our initial search yielded 625 articles when we used those key search words, and then we narrowed those articles down to 9. Those include 2 meta-analyses, 4 prospective double-blind randomized trials, 2 retrospective chart reviews, and 1 prospective randomized placebo-controlled trial. And between those 9 articles, there were a total of 7,139 participants.
This is a visual aid for what Sarah just talked to you guys about. The 625 articles was our first search find. We narrowed that down to 17 full text articles that met our search criteria. From there, we excluded 8 articles. for being either non-peer reviewed, invalid, or retracted. That left us with our 9 final articles that met inclusion criteria. Those included our 5 RCTs, 2 retrospective studies, and 2 meta-analysis. These next couple slides are our charts from our literature review. They give us a visual aid of our studies. They're grouped by type of study. They show the data that we found and the medications used. This first one is our randomized controlled trials. The next one is the retrospective studies, of which we had 2. And the last one is our meta-analysis studies, of which we had 2 of those also.
The next portion of our presentation is where we're going to discuss the articles that we included in our literature review. We'll start off with the randomized controlled trials. The first of those is a study from 2013 by Kim and others. Like I said, this is a prospective randomized double-blind study. The patients were all female, undergoing thyroidectomies, ASA status 1 or 2. This study had a total of 94 participants. They divided those into 3 groups. The first group received midazolam 0.75 mics per kilo preoperatively. The next group received remosatron 0.3 milligrams. And then the third group received both of the medications at the same doses. And the findings of this study, the group that received both medications had significantly less PONV. And then from there, the midazolam only group had lower PONV rates than the remosatron only group.
Horniman et al. Published a double-blind randomized clinical trial in 2016. They included ASA 1 or 2 patients, totaling 140 patients. They divided them into 4 groups. One group received solely midazolam. The second group received only ondansetron. The third group received a combination of midazolam and ondansetron, and the fourth group received only saline. The data showed that the incidence of PONV was significantly less in the combination midazolam and ondansetron group than both the sole midazolam or ondansetron group in the first 24 hours. The statistics were very clear, the effectiveness of the combination over the others. 71.4% of group S, which is the saline group, required an additional antiemetic compared to only 11.4% of group MO, which is the combination group. And then 31.4% of group M and 34.3% of group O that only received 1 antiemetic required a rescue. So the results show the administration of midazolam at 0.75 milligrams per kilogram combined with ondansetron 4 milligrams was much more effective than using midazolam or ondansetron alone in prevention of PONV.
Our next randomized control trial was done by Lee in 2007. It had a sample size of 90 patients, ASA 1 and 2, ages 18 to 65, undergoing minor urological or gynecological procedures. This study used doses of 2 milligrams midazolam versus 4 milligrams of ondansetron, and both of those medications were given about 30 minutes prior to the end of each case. Their findings resulted with midazolam decreasing PONV by 30% versus 27% decrease with ondansetron. So they also found that the midazolam group did not have any increased discharge times or length of stay with that also.
Sanjay et al. Published a prospective randomized double-blind clinical trial in 2004. They studied CABG surgery patients that were on cardiopulmonary bypass during surgery. Their sample size was 200 patients. They divided that into 2 groups. The mean age of these participants was 60. So how they studied this was by giving one group a midazolam infusion, another group ondansetron. Both of these started after the patient was off cardiopulmonary bypass. Their results included the first 24 hours after this period. So the midazolam group received an infusion of 0.02 milligrams per kilogram per hour, whereas the ondansetron group received 0.1 milligrams per kilogram IV Q6. The results showed that no patients in the midazolam group that experienced nausea required a rescue antiemetic. All patients that were in the ondansetron group that experienced nausea required a rescue antiemetic. So those results were pretty clear to us on the effectiveness of midazolam. Bauer et al. Published a prospective randomized placebo-controlled trial in 2004. This study included ASA 1, 2, and 3 patients scheduled for surgery. They totaled 88 patients. 2 randomized groups received either 0.04 milligrams per kilogram of midazolam or IV saline. The results showed significantly fewer patients in the midazolam group experienced nausea and vomiting in the first 24 hours than the control saline group.
Our next article, the next 2 are retrospective studies. So this is the first of those 2. It was conducted by Wilson and others in 2009. This study was a chart review. They looked at 2 years worth of patient charts at a facility in North Carolina. They wound up including 196 subjects. They were all female, undergoing breast surgery of different types, and they ranged from inpatient and outpatient. They only looked at midazolam administration in this study, and they evaluated the need for rescue antiemetics in the PACU or additional medication use in the PACU and PONV rating scores. The findings for this study was that there was no difference in the PONV rates between the inpatient and outpatients, but there was a significant difference. Patients that didn't receive any prophylactic treatment had much higher incidences of PONV postoperatively.
Our second retrospective chart review was done by Majumar in 2019 at a large outpatient cancer facility. They had 15 months of data collection, various ranges, types of surgeries. These patients were ASA 1 through 3 and received either general anesthesia or MAC anesthesia. So their sample size was 4,057 patients total. The most common dose was 2 milligrams of midazolam that was given for each patient. The researchers concluded that the midazolam given intraoperatively can decrease rescue antiemetic demands in the PACU area by about 3.2% when compared to just the ondansetron itself. Our first meta-analysis was done by Grant and et al. In 2016. They covered 12 randomized controlled trials. These are patients receiving general anesthetics. They had a total sample size of the 12 trials for 841 patients. The midazolam dose range was 0.04 to 0.075 milligrams per kilo up to a 2 milligram dose, and those are given IV bolus. Over all of those trials, the results showed about 50% decrease in nausea and vomiting in recovery, with a secondary analysis showing a decreased need for rescue antiemetic medications.
On et al. Published a systematic review and meta-analysis in 2016. This included ASA 1, 2, and 3 patients ages 18 to 75. Multiple types of surgical procedures were included in this systematic review. The sample size totaled 1,433 patients, and it studied midazolam as an antiemetic. The data from this showed that pre-medication with midazolam can prevent PONV in 1 and 3 patients that would otherwise have experienced PONV. Also, it showed that fewer patients in the midazolam group required a rescue antiemetic.
Our analysis of our literature review, the sample population that we included were male or female patients, ASA 1, 2, and 3s, over the age of 18, and patients receiving general anesthetics. Our study were not excluded from this literature review based on type of surgery, dosages of the midazolam, or by combination of antiemetic medications used.
The gaps and omissions for our project. There are 6 different classes of nausea and vomiting medications. We only included 3, only 3 are represented here. Was a lack of current studies evaluating midazolam as the sole PONV prevention medication. Only a few of our studies only looked at midazolam. Several of them compared them to usually a 5-HT3 antagonist. The age of some of these articles is another limitation. Some of these articles are 10 to 15 years old. There's limited representation of surgical procedure types, and not all types of surgeries are included in the studies. There's limited anesthesia type. We only limited it to general anesthesia, and there were MAC cases included in one of the studies as well. And then the retrospective design of 2 of the included articles does threaten the validity of the information provided in those studies. The authors do mention it in both of those articles. They mention that the accuracy of the records utilized for the study's purpose couldn't necessarily be verified.
Ethical considerations for our project included, we did a literature review, we obtained IRB approval, and no human subjects were utilized in this study.
Our study limitations included novice researchers, a low budget, time constraints, and a literature review.
So our recommendations from conducting our project, after reviewing the results of our literature review, in order to decrease the incidence of PONV, we believe that midazolam should be considered for its antiemetic properties. The current research supports both the mechanism of action of midazolam and direct data collected from patients in the 24 hours following surgery as proof of the effectiveness of midazolam as an antiemetic. We also concluded that a rescue antiemetic was less likely to be needed when midazolam was part of the PONV prevention protocol. And then some recommendations as far as additional research goes. We would recommend that studies should be conducted to determine an ideal dose of midazolam for this purpose. Several of the studies used weight-based doses, and then other studies used just a general dose of 2 milligrams. And then to allow for a more consistent comparison, future research should look at midazolam use alone for prevention of PONV compared to other commonly used PONV medications. And then we also recommend that studies on both high PONV risk surgeries and lower PONV risk surgeries be conducted. And then further studies should continue to include an assessment of the individualized need for rescue antiemetics. And lastly, here are our references. And that's our presentation.